So I'm going to talk about a relatively new parameter, OCT-based parameter that might be able to help us in diagnosing glaucoma and maybe even the progression of glaucoma. So we'll start with some basics first. We'll talk about the clinical definition of the optic disc. And what you're looking at when you look under the slit lamp or at a stereophoto is the visible surface of the neural and connective tissue of the optic nerve head. And as clinicians, we have to delineate the inner border of the cup and then the outer border and the disc margin. And then we can use some sort of estimate, such as the cup-to-disc ratio or rim area, to try to approximate the amount of neuroretinal rim that the patient has. Specifically, we'll focus a little bit more on the disc margin or the outer border, and it's previously been assumed to be a single anatomical structure that helps delineate the neuroretinal rim. It's been defined as the inner edge of the sclera or border tissue of Elschnig, and it connects the scleral canal, or the lip of the scleral canal, to Bruch's membrane. So here's a quick photo, and kind of when I approach the patient, sit down and look, you try to find the cup, you find the margin, and then you can make your assessment of the neuroretinal rim. Now, a problem that we have, especially that I run into in the resident clinics, is that you have a different clinician looking at the patient at every single visit. So I look at the patient, kind of think about what I would put in the note, and then I look at the last note and see something that to me is way off. So that tells me either that I'm really bad at what I'm doing, or the person before me is really bad. And I like to go with the latter. So I go find that person and ask them this. But in reality, there's differences not only between residents, but even experts. There's studies that have shown that cup-to-disc ratios can differ by as much as 0.16 disc diameters with stereophotos, and even using more sophisticated technology such as confocal scanning laser, where you still have to manually delineate that outer margin, sometimes up to 8% difference. And that could, be significant in patients with glaucoma who you're on the border about whether you want to treat them or not. There's another recent paper that was published that showed that the clinical disc margin as mapped by physicians was larger typically than the true anatomical margin as delineated by OCT. So the good news is that we're not doing anything wrong. With advances in OCT technology, we've been able to see that the disc margin is rarely this continuous single entity. Rather, it's made up of a couple different structures, such as that border tissue, as well as Bruch's membrane opening. And the reason the termination of Bruch's membrane plays a role in this is that there are invisible extensions that we can't see at the slit lamp, we can't see on photographs. And if you think about an intact Bruch's membrane, the axons are not going to go through Bruch's membrane. They have to extend past before they dive into the scleral canal. And so that would stand to reason that would be the true anatomical margin of the outer neuroretinal rim. Another thing that disc photos don't really always take into consideration is the orientation at which the axons enter the rim. So axons that come in on a more horizontal plane, such as on the right on this photo, versus axons that come in more parallel to the visual axis, it may be the same number of axons, but the one on the right might appear to be a larger neuroretinal rim when you're examining the patient. And this illustration on the left also demonstrates kind of what I'm talking about, where you see that border tissue, but you see how in some parts of the optic nerve head, the termination of Bruch's membrane can extend past that border tissue. So this recent parameter that's been discussed is BMO MRW, and BMO stands for Bruch's membrane opening. The reason they like to use this is that it's a structure that's continuously and consistently seen on OCT around the entire optic nerve head. It's almost always easily identifiable on these OCT scans. And MRW stands for minimum rim width, which is just the minimum amount of distance from the termination of Bruch's membrane to the ILM of the nerve fiber layer. And as opposed to other OCT parameters or confocal parameters, which use a fixed horizontal plane, this helps account for the orientation of those axons as they come in to the optic nerve head. And this parameter was recently shown to improve the ability to detect glaucoma compared to confocal and other OCT measurements. So an illustration from the same paper with just the addition of that line that shows how we delineate the BMO MRW. You can see how it can help take into account the orientation of those axons. And at the bottom is just an OCT picture, and you can see the termination of Brooks membrane is that stark white line, and that's what it looks like in all the scans all the way around the optic nerve head. And beneath that is somewhere is that border tissue that we look for in disc photographs, and you can see how that's a little bit harder to identify, especially in the picture on the bottom right of your screen. Not really sure where that would be, so we use BMO because it's just easily identifiable on these scans. So this was from a separate paper, and if you look at the photograph in the middle, the green dots are the disc margin, the clinical disc margin as mapped out by a clinician, and the red dots is the anatomical disc margin after it's been co-localized with the OCT to Brooks membrane opening. And you can see in the temporal part of the disc, there's some parts where they line up pretty close and they're pretty similar, but in areas, especially that are in this case susceptible to glaucoma injury, such as the superior and inferior poles, you can see that the clinician thought the disc margin was actually much wider than what the anatomical disc margin ended up delineating. So this patient would have a smaller rim than you would anticipate and more damage from glaucoma. So our study, we wanted to know if there was a difference in BMO MRW across races. We know that people of African descent have an increased susceptibility to open-angle glaucoma. We know that there are studies that have shown that there are racial differences in the optic nerve head tomography, such as larger cups or increased cup-to-disc ratio. And the previous BMO MRW studies have been based on normative databases that were strictly used population of European descent. So using the equality study, we were able to obtain OCT scans of normal eyes. These are patients that did not have a history of glaucoma and did not have glaucoma on their comprehensive eye exam. And using OCT, we had 24 radial B scans that were spaced 15 degrees apart for 48 BMO points on the optic nerve head. All the images were reviewed, and then the BMO location was manually adjusted if we needed, and then we adjusted for age, gender, and BMO area. So a couple of our results, we had 308 eyes that we were able to analyze. And what we found was that there's, in a cross-sectional analysis anyway, there's an age-associated decline in both the global and the regional BMO MRW across racial strata. And this kind of confirmed from a previous study that showed that with increasing age, the BMO MRW is thinner. And histopathology studies have shown that there is a loss of retinal ganglion cells over time, even in normal patients. So this kind of makes sense that the BMO MRW would be thinner as we get older, even normal eyes. And then kind of the main results that we looked at for our study was just between the people of African descent and European descent. What we found was that there was no significant difference after we adjusted for age and gender in the BMO MRW, both globally and in areas more prone to glaucomatous injury. So what we conclude is that race-specific normative data may not be needed for BMO MRW, and we can start using the databases that we already have based on people of European descent, and that this BMO MRW can be incorporated into the OCT exam for a more accurate measurement of neuroretinal rim, not necessarily as a replacement of the clinical exam, because like Dr. Gerken was talking about previously, there's still things that we need from the clinical exam: disc hemorrhages, the overall health of the disc, the color, whether there's pallor, atrophy. But this may help in patients where you're worried, are they borderline? Do they have glaucoma? Do they not? Or hopefully maybe we can refine the technology even more and be able to detect progression of glaucoma earlier. So that's it. Thank you.